disease clusters.
Sorry about that.
Why study disease clusters, given the fact that they are difficult sometimes to investigate, and often we don't get an answer that we want, or the community wants. So why study them? First of all, health department needs to be responsive to public concerns about health. It's an opportunity for the health department to provide health education about cancers, and to, if necessary, and it's obvious that the cluster is not related to some environmental or occupational cause, to allay concerns, but at the same time initiate investigations when concerns are well-founded. So that's one reason. The second reason is to encourage prevention or remediation of environmental hazards. For example, in Toms River, New Jersey investigation, they evaluated and found several potential exposure pathways and investigated them, and also found an unknown hazard, a chemical that was never seen before in the drinking water. And at the same time, they were able to shut down contaminated wells that they discovered during the investigation. So there is that intervention aspect. At Brick Township, a cluster was a sentinel for an emerging health problem. So that's also a reason to investigate clusters, because they may be sentinels for emerging health problems. And again, to reduce exposures in the community in some kind of intervention. A third reason is to facilitate scientific discovery. In the cluster investigation in Woburn, Massachusetts, they had identified a new exposure disease link between trichloroethylene exposure in drinking water and childhood leukemia, which was then also confirmed in a study in New Jersey I was involved with, which was a data linkage study, which is another thing that's important when you're looking at clusters, to have the ability at the state health department to link environmental and disease registry data. And then the fourth thing was to improve our methods. The Long Island breast cancer investigation in the early 1990s spawned a whole lot of geospatial analytic methods that are used today by health departments. In Woburn and then at Toms River, methods to do historical reconstruction of drinking water exposures using distribution system modeling were pioneered in those studies, and we're being used now in Camp Lejeune studies, for example. Biomonitoring in Fallon was used, and that was a useful approach. And clinical tests were used in the Brick Township cluster investigation. And finally, as I was saying just a minute ago, data linkages are also promoted or encouraged by investigating disease clusters. So, and there have been some successful cluster investigations that resulted in causal associations, and some of the key ones are benzene and acute myelogenous leukemia, asbestos and mesothelioma, vinyl chloride and angiosarcoma of the liver, dyes and bladder cancer, the Woburn study, which associated TCE, contaminated drinking water, and childhood leukemia, and a couple others that aren't occupational or environmentally related, such as DES and vaginal cancer, and thalidomide and musculoskeletal birth defects. So there are cluster investigations and clusters that lead to causal associations, but again, many don't. So let's get to the to what is a cluster and the cluster definition in the CDC's proposed new guidelines. First of all, there's no consensus for a definition of a cluster. So the CDC definition is one I'll go over with you. So their definition is a greater than expected number of the same or etiologically related cancer cases that occurs within a group of people in a geographic area over a defined period of time. So I'm going to break this down for you. But one advance this definition has over the 2013 guidelines is it adds the notion that etiologically related cancers should be investigated, not just the same cancer type, but if you have some idea that several cancers are etiologically related to the exposure you're interested in, then you should focus on that and not just focus on one particular cancer. So they open it up to a broader possibilities for what you would look at. So let's start with the first part of the definition, a greater than expected number. And then the guidelines say when the number of observed cases is greater than typically observed in a similar setting. And of course, there's no information on what a similar setting is. So that's a problem right there. The next question is, well, how much greater? The health departments calculate what's called a standardized incidence ratio, which is the observed number of cases divided by the expected number of cases times 100. So is an SIR, standardized incidence ratio of 101 worth looking at? 105, 110, 150? Where do we say, all right, this is greater than expected and we're going to take it seriously? There's really no guidance for that in the guidelines, and it's an arbitrary decision. Some health departments, many use p-values to determine that, but that's arbitrary as well. And there's some question as to whether even significance testing is appropriate because of the circularity of the approach, the data giving you the cluster and then using the data to evaluate the cluster. So it violates certain assumptions that go into significance testing that I don't go into, but significance testing has its own problems. And in fact, so much so that the guidelines state that significant testing should be done, but it should not be the deciding factor. And they mention that a few times in the report. So, but in order to calculate a standardized incidence ratio, you need a reference rates. So again, the question is, which reference rates? State, county, national? These again are decisions that go into any calculation of a standardized incidence ratio. The next part of the definition is of the same or etiologically related cancers. So this is a question of case definition. And then the question becomes, do you lump or split? Do you have a narrow focus on a particular type of leukemia? You look at all leukemias. Do you look at leukemias and non-Hodgkin's lymphoma together? So on and so forth. So again, these are decisions that have to be made in order to even calculate the SIR. And then the next part of the definition is that occurs within a group of people. Okay, what people? What age group? Should we focus just on males or females? Is it occurring more in males than females? Maybe we want to focus on a vulnerable population based on environmental justice issues. So again, another decision that has to be made before you can calculate that SIR. And then the geographic area. What geographic area? Sometimes health departments use a geographic area that they have data on, whether it matches what the community is interested in or not. And that's a problem. So how do you define the area? And then the time period. How do you define the time period? A lot of health departments use 5-year cancer rates or 10-year cancer rates, but that's not, but maybe the exposure has a different time period than that, or at least the exposure of concern. So again, these are all decisions, and any decision you make on any of these aspects affects whether you'll see a cluster or not. So you can make a cluster disappear or appear based on your decisions on all those aspects. So the bottom line is, who decides these decisions? How should these decisions be made? The guidelines do give some emphasis, and I think this is important, on being involved with the community, interacting with the person who calls in the cluster report and working with that person, but does not really say who makes the decisions on all these aspects and how that's done. And that's one of the shortcomings of the guidelines. My own view is that there needs to be interaction with the community so they have input into all these decisions. So there's another definition of cluster that I like better. It's, I think the statistician Knox put forward many years ago, and it's an aggregation of health events related to each other through some social or biological mechanism. So it's not just health events or a higher number of health events, but there's some reason why we think that there's something causing that cluster, and we have some evidence for it. So that to me, focus your attention away from significance testing, away from calculating a standardized incidence ratio before you're ready to do so, and collecting information and trying to develop a hypothesis as to what actually we think might be behind that cluster. And you work with the community to come up with that hypothesis. Once you have that hypothesis, then you can make decisions on all those aspects that I just went over. You know, how to decide how large an SIR will be important, what the time, space parameters are, what the case definition is, and so on and so forth. So it's more of a shoe leather epi approach where you gather a lot of information first. You do a preliminary exposure assessment if you can, gathering all that information, working closely with the person who called in the cluster investigation or the community group that's involved with that cluster, and coming up with an approach that both the community and the health department can agree on as to how to proceed before they start calculating the SIRs and doing all that, the stuff they usually do right away. Okay. So there are three phases in the guidelines that are being proposed. The first phase is initiating lines of communication, and I think this is pretty straightforward. You try to get from the person calling in all the information you can possibly get about the cancer, the age of the people with the cancer, geographic area and time period you're worried about, and any specific environmental exposure concerns or occupational exposures, or is it a school that we're talking about, and so on. So you get all that information from the person, and then you move to phase two, where you calculate the standardized incidence ratio. And again, I think that before you do that, it really is important to actually involve the community in all those decisions before you calculate the SIR. And again, that's not in the guidelines sufficiently for my liking. But the second phase, once you calculate the SIR, the standardized incidence ratio, then you answer these questions that are in phase two, such as, is the observed number of cases more than the expected? Is the difference statistically significant? Is there a temporal or spatial clustering? Are there patterns of cancer that look unusual? Well, obviously they would be because it's a cluster. And are there some shared risk factors that might explain that cluster? So you answer each one of these questions, yes or no. And if you answer the first question that it's more than expected, then you continue with the investigation. If you don't get an SIR greater than 100, then I guess you stop at that point. And then you answer additional questions about the environment. Whether there was an environmental concern, does it make sense biologically that exposure of concern could cause the disease? Is the latency period appropriate for the time period of the exposure, and so on? So these are also questions that the health department could ask and answer before they continue to phase three, which is then a much more elaborate investigation, could involve epidemiologic studies. And at this point, and only at this point, do the guidelines talk about establishing a community advisory committee or a CAP or something of, for example, like the PEAS CAP or something of some participatory mechanism so that the community can have input into how the investigation will proceed from then on. But again, my view is that should happen much, much earlier in the process. It should happen in phase one, not phase three. And I've made this point during the 2013 discussions for those guidelines as well. There is a lot of resistance to having that kind of community input at the start of the investigation. And I think that's unfortunate. I think that community involvement at the beginning of the investigation not only makes the investigation more acceptable to the community, but also improves the science in my own experience. So to improve the guidelines, again, I would want to set up some kind of participatory mechanism as soon as possible in the process in phase one, before you calculate the standardized incidence ratios. And I'd also do not recommend significance testing at all. But that's my view on it. And also, I think it's important to develop an explicit hypothesis in phase one before you calculate the SIR. because, and with some justification, some reason why you're making these choices. Oftentimes, health departments make all these choices, calculate an SIR, but they don't give reasons why they're picking a p-value of 0.05, why they're assuming that a SIR of 105 is not high enough, why they're picking this particular geographic area, how they're defining it that way, why are they looking at this particular time period, why this cancer cases that they're looking at and not expanding or narrowing the focus, so on and so forth. All these decisions are not justified. They're just done. And with no explicit justification. So it would be important to have that justification. And again, working with the community might help them do that. Okay, so let me get into some of the investigations that I've been involved with. So the first one I'll talk about is the Fallon, Nevada Childhood Leukemia Cluster. Fallon is a rural area, small population. They expect maybe one leukemia case every 2 years, but in a 2-year period, they got 11 cases. And 10 of them were acute lymphocytic leukemia. And they had 10 cases, less than one expected, and the p-value was 4 times 10 to the minus 9. So a lot of zeros in front of the
I found this on the web.
and it was probably the most in-your-face cancer cluster I've ever seen. But the interesting thing is that it did not result in a successful investigation. So the p-value, a very low p-value, does not guarantee success. In this case, it was identified by an alert health provider, and most of these clusters are found by alert health providers or alert citizens. And in each of the 4 cases I'm going to talk about, that was the case. So the investigation looked at several exposure scenarios. We didn't really know why there was this elevation suddenly in this town. So we looked at, there's a naval air station, the Top Gun state, the actual Top Gun naval air station. And so there was worry about jet fuel emissions from the planes. There was a jet fuel pipeline going through the town. There was arsenic in the drinking water, naturally occurring arsenic, at the highest in the country. And there was tungsten manufacturing and emissions of tungsten into the air in the community. So there were a couple of things to look at, but we really didn't know. And then there was a viral hypothesis as well. The incoming population coming into the naval air station might have introduced a virus into the community that they were not, that could set off a leukemia cluster. So that was hypothesized too. So there were several hypotheses, but nothing that really stood out. So what was done was a biomonitoring program. So we looked at a wide range of measures. We looked at metals, we looked at mostly metals, but we also looked at other chemicals in blood and urine to see if there was anything in excess. And there was not. The cases had high levels of tungsten, high levels of arsenic, but so did the controls. And in fact, in some instances, the controls had slightly higher than the cases. So it didn't pan out at all. So given that, in desperation, I tried to use a space-time cluster method to see if the data would tell me what was going on. Was there some pattern of the cases that could link it to some kind of exposure pathway? But that was also unsuccessful. So in the end, the lessons from that investigation were, again, the statistical significance does not suggest that the cluster actually can be, the cause of the cluster can be found, and that there needs to be better environmental data. And biomonitoring, especially a biomonitoring program with no focus, is not necessarily going to be the best approach to doing a cluster investigation. Much better to have a targeted one, like the one, for example, the biomonitoring for PFAS that was done in New Hampshire. Okay, so the next investigation I want to talk about is the one in Woburn, Massachusetts. And that was a childhood cancer cluster as well. Alert Citizens identified this cluster. And they actually proposed the hypothesis to the health department. So they were many steps ahead of the health department at the time. At the same time that they were, the families were identifying all the leukemia cases in the town, there was a discovery that a well or two wells in the serving part of the town was contaminated with trichloroethylene, and they were immediately shut down. So that was interesting, and the community latched onto that and said, "All right, let's study whether this contaminated drinking water caused this leukemia." And it took the health department a couple of years to come around to actually looking at that. Actually, initially they didn't look at it. The Harvard team looked at it, and then many years later, the health department did the final version of the study. And to do the study, you had to do distribution system modeling to figure out where those two wells served, what parts of town they served, and what parts they didn't serve. So that's I think the first instance of using this kind of distribution system modeling to historically reconstruct where the water went over time, and to use that in a case control study. And the result was that the contaminated wells were strongly associated. The odds ratio was about 8 for the cases versus the controls. There were 19 cases, 37 controls. So it was just not a big study, but it was a strong finding. And so it was the first time we heard of such a association between trichloroethylene and childhood leukemia. And in fact, inspired New Jersey Health Department to look at the same question using a data linkage approach. In their case, they had drinking water data for the state on TCE in the municipal water supplies for TCE, PC, benzene, and so on. They looked at the TCE and the perchloroethylene information and linked it with the leukemia data from their cancer registry to do 2 studies to look at that, and found, again, childhood leukemia related to TCE. So it was interesting. So this cluster investigation not only found a new link, but inspired another health department to do a data linkage study. So it's been very important. Okay, so the next one I want to talk about, and by the way, you can interrupt me, or at the end we can ask questions in either way you want to do it. So for Toms River, New Jersey, that was both childhood leukemia and brain cancer investigation, and it was mostly in females. What happened there was a health provider sounded the alarm. I think there was the Children's Hospital in Philadelphia, and the New Jersey Health Department then used their cancer registry data and saw that there was a higher rate, especially among females, of childhood cancers versus the rest of the county, and of course the rest of the state. And then they used the registry to identify cases for a study. And in this case, again, distribution system modeling was necessary to look at the different well fields serving the town. And the fact of the matter with Toms River is it was a very small community in the early 60s, and then expanded greatly because of the Garden State Parkway that was built. And so you had a very small water distribution system situation in the early 60s that expanded greatly. And so this again enhanced our ability, or pushed us to enhance our ability to do distribution system modeling. And that was key to the Toms River investigation. But they also did air modeling of the chemical plant emissions that was in the town, the chemical plant, and also a nuclear power plant that wasn't too far away. They also did some air emission modeling for that as well. So they looked at least 3 different pathways: water, drinking water, the chemical air emissions, and the nuclear plant emissions. Didn't see anything with the nuclear plant emissions, probably too far away. The chemical plant air emissions and the drinking water, they did see associations with childhood leukemias, in particular among females, again, because that's where the excess seemed to be. So it wasn't so much in males, but they did see pretty strong associations with females. And all throughout the process of the investigation, there was a community advisory committee who worked closely with the health department and the investigators, so that each aspect of the investigation had to be approved or at least agreed to by both parties, the health department, investigators, and the community. So that, I thought, was very helpful, because at the end of the day, the community were, even though the results were not crystal clear, were willing to accept the results. And at the same time, one of the important things about the Toms River investigation was, during the investigation, they found a well that was contaminated and were able then to shut it down. So they probably would not have found that contamination if the investigation hadn't happened. And so the intervention reduced exposures. So finally, Brick Township, which is right next door to Toms River. And this is an interesting situation. There hadn't been a prevalence of autism done in the US since the 1980s. And this cluster was investigated in 1998, 99. I'm trying to remember exactly when, but so it was at least 10 years later, looking at prevalence of autism. The cases, pretty much all the cases, were identified by a couple who had 3 children, 2 of whom had autism. And I was involved in interacting with them. And one of the things that the cluster guidelines say is you should have empathy with the parents. And in my case, I had very much empathy with them, because I also had 3 children, 2 of whom were autistic. So we were able to have a good rapport right off the bat because of that. They had an expert on autism from Rutgers. And he initially, when we developed the protocol for the investigation, we were going to use the same approach that CDC had been using in its other surveillance methods, which was to focus on school records and medical records to identify cases and to come up with a prevalence. And after discussion with the couple and their expert, I decided to change the protocol and include clinical examination of the children, not just using school records and medical records. And that made the prevalence a whole lot more valid, and people took it a lot more serious, because we actually had clinical evaluation of the children. And this resulted in the prevalence of autism in the town 10-fold higher than it was in the 1980s. And this was the first indication that autism prevalence was rising rapidly in the US and elsewhere in the world. So this investigation was a sentinel event, telling us that this was an emerging problem. Now, the couple had a hypothesis they wanted us to look at, and it was a drinking water hypothesis based on some research actually I had done in New Jersey, looking at disinfection byproducts like trihalomethanes and birth defects. And one particular birth defect, neural tube defects, the key period of time when of the exposures during day 24 to 28, roughly in the pregnancy, so very early in the pregnancy. And there was another study that said that that's also a period when autism might be impacted by exposure. So they took my study and this other study, put them together, and came up with the hypothesis that disinfection byproducts might be causing autism. And at first I thought that was amazing thought process. I wouldn't have come up with it. And so we decided to look into it. And we, again, used space-time cluster methods to see if the cases corresponded to where the hot spots in the town were for disinfection byproducts. This is a community near the shore, so people don't live there year-round in places, and the water sits in the pipes for a long period of time, and the disinfection byproducts then get higher and higher in the pipes. So there are hot spots in the town, and but we didn't see, unfortunately, we didn't see a link there. But I consider it a important and successful investigation just for the fact that we're beginning to realize how the prevalence for autism has increased. So that's about it for my remarks. Questions?
Thank you so much. I'm sure there are going to be questions in this group, so I'll see if anyone has any questions for Dr. Bove.
I do have a question. Have you had a chance to take a look at the cancer cluster investigation from Coakley landfill at all? And if so, do you have any comment on that?
I've only looked at it very slightly. I know that it's rhabdomyosarcoma that we don't know much about in terms of etiology. I've seen some reports about x-rays that mother might have had. There's one study that looked at military service of both males and females and Agent Orange, and there was some associations there, but the problem is with any study of a rare cancer or rare birth defect is you have small numbers, extremely wide confidence intervals. So that doesn't mean you should ignore the findings because there's wide confidence intervals, which oftentimes people do, but it does mean that there's a lot of uncertainty in that estimate. So additional studies would be helpful to try to see if in fact that is a problem, whether Agent Orange or some kind of military service might be related. The problem with the parent might be related to the child developing that disease. So that, but no, I don't have any other ideas. I know that PFAS was found at Coakley. They're probably, if it's a landfill, who knows what in New Jersey, landfills have all kinds of stuff in them, all kinds of chemicals, all kinds of dumping that occurred. I don't know if that is the case with Coakley or not.
It is. Yeah, Coakley is, I don't even call it a landfill, it's a dump. There is no liner underneath it, and there's everybody and anyone could dump in that facility. I thought your discussion was really interesting and important. I don't mean to jump in if you have some more you want to ask. You know, I was thinking my way through this, you know, when I identified that cancer cluster, would my identification have met what you proposed to be the way that we should go about this? And we didn't have any, we still don't really have a causal connection with anything. I suspect PFAS exposure is in part related. So I don't know if it would have, you know, gotten past your, what you were talking about. There was so much stuff that you said about the questions that came up in the community about why did you pick 5 towns? Why didn't you include Hampton? And I remember, as you know, Representative Cushing was a big, you know, he wanted to be involved in it because he didn't understand why Hampton was excluded from the study and should have been. And I do think that that's true. So all these questions came up, and I sort of wondered if this would have met your criteria for additional investigation. And, you know, we still have a lot of concerns about that, as Representative Muse brought up about this cancer cluster investigation in the Seacoast.
Yeah, well, see, all those questions that were raised could have been resolved initially before they started, you know, and actually that could have guided an exposure assessment, looking at different pathways, trying to better define the area of concern, and the time period of concern.
That was a big
to
thing.
do all that preliminarily before you, but see, health departments tend to move quickly to the calculating that SIR and then dismissing the cluster, because doing what I'm suggesting requires a lot more work. I mean, there's no question about it. But at the end of the day, you have the acceptance of the community for what you've done because they were involved in making those decisions with you. Right. And it, you know, that's what was done for the peace study. A cap was established, and, you know, the approach to the study was discussed with the CAP all along. I mean, we didn't always agree. Wasn't always agreement, but I think if they, at the end of the day, they understood why the ATSDR did certain things.
Yeah, for instance,
I don't know. I haven't seen your standardized incidence ratio for the cluster. I don't know what.
I'm going to send it to you.
The health department decide. And again, I think that without having a firm idea of what the exposure might be and well defining the area based on that and the time period based on that, I don't have much respect for the SIR, I guess.
Yeah. Yeah, another question that came up from the community was there are all these 19 other RMS cases just before their defined timeline, time frame for the study. So that was another factor that made people feel uncomfortable that that was really not even, even though it was a cancer cluster, it still wasn't enough of a, it wasn't defined well. So it was problematic for us.
Yeah, and some of the issues I didn't mention were, what do you do with people who moved away? Migration is a very important issue, especially for childhood leukemia. Well, especially for adult leukemia too.
Right,
People do
right.
move,
Yeah.
but even for childhood leukemia and birth defects, people move enough so that and move out of the area. And so, do you capture them, or you just focus on the diseases, the cases that occurred and still are in the area of concern? And that's again something that should be discussed with either the community or the representative or the person
Right.
who's being inquired for.
I can see Representative Murphy has a question for you.
Yeah, I just wanted to say thank you for that presentation. It was awesome. As you spoke, so many things were popping up in my mind about our experience here in Southern New Hampshire. And as you mentioned, the community input is so important. I think, as myself, I was a citizen advocate. I was a mom. I'm a retired nurse who was a mom who started, just noticing things here in the community, just in conversation and anecdotal information. And I'm a mom who happened to adopt half of my children, including one with autism. And interestingly, I at the beginning, I said, you know what, look, I've got 6 children I was adopted myself. So I said, I'm not biologically related to my children. They're not related to each other. And I've got in this house, including my husband, cancer and every kind of health impact amongst these children that are known to be associated with PFAS exposure. 2 miles from the site of St. Bove, and also from the most contaminated wells here. So it didn't, can I say that, PFAS caused these issues? No, I can't. Look at my neighborhood, 6 houses here, all in line. We have 7 children with autism, 1 deceased at age 7 with AML. And my frustration, as you can imagine, has been trying to encourage our health department to look at the long-term exposure that we've had here to PFAS and multi-generational. My kids have lived here and my kids drank gallons of this water, of course, every day all their life. And they've had children now who are entering our public school systems, and our special ed budget's going up. And a while ago, as a citizen group, it was a health survey because we kept asking for a health study, given the cancers and the thyroid disorders, that kind of thing. And, it never really rose to the level of we didn't get the response that we'd hoped for, blood testing and those kinds of things. But just a voluntary survey we went door to door, left surveys, and people just called in because they started to be, aware. And all of the things that came up just on a citizen survey were not knowing what people were what we were looking at, but the number of thyroid disorders and those kinds of things were really concerning. And then when, so we pushed our state for the cancer reports and cancer studies. And back in 2016, we were told there's no, statistical significance. And then we asked for updates, and wasn't till this December with this commission pushing for, we said, you know what? There's just way too many cases we're hearing about in our communities. Don't tell us there isn't. This is our reality. We're living it. And finally, the cancer report came out here, and we asked about the SIR that was chosen, and it was okay. The kidney and renal pelvis cancers are above, the SIR, but what do we have? Maybe 4, I think, other cancers that were right below. And we asked, well, are we not to be concerned about those as well? And how did you decide on that SIR? And it was it was just a choice they made. They said they could have chosen a different one, but didn't. So it's, you know, what you're talking about is, you know, we feel like we have so much information in a hugely impacted population, just in this one community of 28,000. There's so much data here that's not being collected. You know, nobody's, the information is here, but it's nobody's looking at it. And so it was really interesting for me to hear, you know, what you're saying, you know, that Knox definition of cluster, and thank you for your work on this, because it just, you know, but I hope everybody gets to look at this video later on the commission and on the HB 737 commission as well, because I think it's important information for everybody to understand why, when things are determined not to be a cluster, that doesn't necessarily mean that that's proof that there isn't, you know, a concern.
Yeah, I mean, I think that I would like a paradigm shift, if you will, so that instead of doing a statistical exercise, the health department would look at it more like a detective would look at a cluster or a murder mystery or whatever, and collect the data that a detective would, the shoe leather epi, as we used to call it, that a detective would do to try to determine, for, you know, what might have caused it first before calculating something like an SIR. Again, it takes more work, but I think that a lot of clusters are dismissed out of hand when they, you know, inappropriately, I would say.
I would agree. Thank you.
I have a follow-up question on one of the comments you made that Representative Murphy is also concerned about. And that was in the Brick Township analysis where you said clinical evaluations were used. So Nancy mentioned it, but we've been concerned about the high rates of special needs spending in this same area where the St. Gobain facility is, and have not been able to get anything. We're trying to, this commission is supposed to look at what do we need to do to change so we can improve surveillance in our state. And so we're trying to pull in some of these things with special needs spending and figure out a way to do it. Maybe you can tell us what you think would be the best thing to do based on your experience, to like, what kind of information would we be looking for? You said clinical evaluations. I think that means you probably did wide scale clinical evaluations of the kids in the town.
There were two key clinical exams that are done at the time, and one was called the ADI, Autism Diagnostic. I'm getting them mixed up. There's an ADOS and an ADI. I'm not up on what the tests are these days. Those were the ones we did back in the late 90s, early 2000s. And, you know, again, that was important to do because we didn't have a prevalence for this country for 10 years. And my own view is that it really wasn't a cluster in Brick Township. It was our first realization that the prevalence of autism had skyrocketed over that 10-year period. And we saw it then elsewhere in the country and elsewhere in the world. But that was the first indication of it in this country. I think there was one other study in Japan where they started to see it as well. But if it wasn't for the Brick Township investigation, I don't know how long it would take before we would have seen this expansion in the rates. So, but a couple of things. One is that there have been studies that look at PFAS and autism. The P study also collects information from school records, and we'll be able to look at autism as well, although probably will not have the numbers. But there is a multi-site, PEACE is part of a multi-site study. And again, the same questions and the same approach is being taken at these other sites. So maybe there'll be enough numbers to look at, but there have been studies elsewhere in the world that have looked at autism and ADHD, and some have found associations, some haven't. So the evidence is mixed as far as I know. But that, you know, PFAS is still something to look at with autism. Other than that, you know, it'd be good to have services for autistic adults as well as autistic children, and that are affordable. Let's put it that way.
Yeah.
That to me is probably the biggest need, finding either independent care for some people who can live independently, dependent care for those who can't, having employment for those who can do it, and so services are the key thing, I think, for autism. I mean, that is my personal experience there.
Yeah.
Talking.
Any other questions? Representative Woods, are you, yeah.
Yeah, I just tagging onto this autism, and looking at it from the standpoint of not really being a cluster, but it was worldwide. We begin to see it worldwide. There still is a mechanism there, which is not clearly defined as yet, if I understand what you're saying. And harking to my physics background, there's a mechanism at play. If there's really truly a baseline increase in autism, maybe we do need to look at it, even though it's quotes not any different than anybody else. That means the baseline has been raised. In other words, an AC/DC, the voltage level has been raised, the baseline voltage has been raised up. We still need to know that. Are there efforts in that regard? I mean, I know there's researchers, but has there been progress, or just because there's not a cluster?
Well, I'm not saying, we could call it a cluster, but it seemed to me that what we found in BRIC was just an indication of where the prevalence was across the world. That what we saw in the 1980s was only the tip of the iceberg, and by the 1990s and 2000 it had skyrocketed. But first, there are a couple of things. One, autism is one of those lumping instead of splitting situations where you lumping together probably a number of different conditions that probably would be better separated for etiologic research, not for services though, but if you want to study mechanism, you probably need to split autism up into smaller groupings that make sense.
Sort of like similar to dementia.
Yeah, and maybe, well, look at leukemia. It's best to look at each one separately, because acute myelogenous leukemia is benzene, but not TCE, for example, or at least not as strong. So it does matter which histological type of cancer you look at, which particular birth defect you look at, and so on, if you're interested in trying to figure out what causes it. But most of the research in autism, until even after the Brick Township investigation, was mostly genetic. And it was a big struggle to get researchers to start looking at environmental exposures. But that finally started to happen. I was trying to remember by the mid to late 2000, 2008, 2009, around there. So the last 10 years, there have been a lot more work done on environmental exposures, looking at air pollution, PFAS, looking at pesticides, and so on. So that's all good. And so there's a body of work that is there and it's being developed. So we'll maybe have a better sense. But I think the same problem is when you look at autism as a group like that, and in fact, look at the whole spectrum as a group, you're lumping together probably diseases with different etiologies. So it's going to be harder to see the mechanism that way.
Well, I think, to me, I'll just offer an additional comment. The previous century was a century of physics, and the perspective of scientific approach had a very deterministic mentality involved with it. The 21st century is a century of biology, and with that, we have to deal with complexity and chaotic phenomena. And mathematically, we're learning how to deal with that in terms of chaos. But that's relatively well worked out. But nevertheless, the intrinsic nature of complexity and chaos processes have left us a rather large void of how do we proceed in biologic systems because of this difference. And we're struggling in all of these venues, dementia, autism, all of these parameters that envelop social. And Mindy and I had a discussion about it earlier, and that is the use of AI to help us understand this data. And so we have the conflating of physics, biology, computer sciences, working with the same topic. And we're just in the infancy right now. And I think the what we're seeing is an expression of that infancy, and we're trying to define what it is we don't know yet.
Right.
Just an observation.
Any other questions or comments? Nope. NAS Fallon has PFAS. You probably know that, Dr. Bove.
Sorry, what was that again?
NAS Fallon has PFAS now. They discovered it there.
Oh, well, of course, because they both trained firefighters to put out petroleum fires, and they've had accidents there, just like at Pease. Well, maybe not as bad as the Pease explosion in 91 or whatever it was, but
Yeah.
1990, 91, yeah. But yeah, you'll see PFAS everywhere where there's airplanes, so airports and fire training. You know, I mean, it's everywhere.
Yeah.
What can I say? There's probably some at Camp Lejeune too, because there's a naval air station.
Yes.
I mean, well, not a naval air station, but just an air station at Lejeune.
All right. Seeing no more questions or comments, thank you so much for your presentation. It was really important. You're welcome to stay with us if you'd like. I'm going to turn it over to Senator Riccardi now to do a presentation on 5G. I know she and Dr. Woods have had quite a bit of experience here in New Hampshire with the 5G issue. So I am going to, do you want me to start sharing the slides right away or wait a second?
I would just like to say a couple things first. I want to thank Representative Salloway for asking me to do this. I do think there's some overlapping issues with the cluster cancers, with our water, air, food, and the wireless radiation. I also want to say that I by no means am trying to suggest we go backwards and not use technology. That's not going to happen. But through the course of the 5G Study Commission, we found that there are ways that we can do it better and more sustainable and safer for people. Senator Sherman, Representative Woods, myself were on the committee, the commission, and we were in agreement with the majority report. So I also will have the slides sent to you because there are links that you can look at everything. And Mindy was so gracious to allow me to upload the work to her site. And so you may want to take a look at that because I did a complete spreadsheet and the 5G committee report is also on there. So I'll briefly go through the slides, and then if you think this is something we should incorporate as we look at cancer clusters, we have been trying to move the needle with legislation. It's very slow moving when you're dealing with industry, but I can now do the slides if that works for you.
Sure.
Representative Woods, feel free to chime in. Just to get us started, these are the relevant findings from the New Hampshire Commission to study the environmental and health effects of the evolving 5G technology. And I'm just presenting it for today, and we can go to the next. I wanted you to see this because there's a difference between 5G, meaning 5th generation, which is a marketing term, and 5G, which is the small cell antennas that they are trying to place in front of people's homes. And I get emails and phone calls daily about people waking up and very concerned. Northampton, I had an email last week. The man and the husband and wife are distraught. It's going to point directly into their young children's bedrooms. So a little bit, if you don't know, the 5G, that is the actual small cell, is not very small in power and radiation, and it doesn't work alone. So it needs to have 4G or 3G with it. So basically, it's forcing people to live in a soup of microwave radiation. And if you're already having issues with PFAS and other things, now you're bombarding your body with this additional problem. If we can go to the next one. I really appreciate you helping me with this. Technology is not my strong suit. It's really not. So the commission was created based on a 5-page report, House Bill 522. I was not in the legislature then, but it was passed with bipartisan support and the governor signed it. And the goal of the commission was to resolve questions and contradictions about the effects of wireless radiation on human health and the environment. So there were 13 of us, and there were backgrounds that included physics, toxicology, electromagnetics. We had Dr. Paul Haru, who's a toxologist and epidemiologist. And we had people from public health policy, business and law, and even someone from the industry. So you'll be getting those slides, and I tried to make it easy so you could just click on the report. Okay, we can move on. There are peer-reviewed publications. They were vetted by the commission. The publications, reviewers, and authors were from very reputable institutions. Outside experts. So the committee met with recognized experts in fields relating to wireless radiation exposure and health. We had many doctors, many epidemiologists. We were all unpaid volunteers. They were vetted to actually show that there is harm. And we did a lot of proof to make sure they were authentic. The only paid representative there was a doctor that was represented by the industry, and he was paid to come for that. Okay, so the major conclusions that we reached was that wireless radiation, including the 5G, poses a significant threat to human health and the environment. There are numerous independent studies that link wireless to cancer, DNA damage, memory loss, impacts to reproduction. When I say this is not a scientific issue, it's a political issue. What I'm trying to say is, just like the tobacco industry, they knew for 4 decades that it was harming people, but they made it political and they didn't want to release this information. And we all on this commission were really trying to bring light to this and to bring out the truth. The Telecommunications Act of 1996 said that health cannot be a factor. You cannot, make the health an issue. And about 6.5 years ago, when I started getting involved in this, because I was faced with it in my own backyard, when I was doing my research, I saw this school in New York, in Bayville Elementary. And after 5 years of the tower being right there at the school, 30% of the teachers and the students got cancers, and 3 of the children died. And it did go to federal court, and they were able to prove it came from the tower, but because of this 19 Telecommunications Act of 1996, nothing could be done. And that tower still sits there today. It's terrible. We can move to the next one. Thank you. So we made recommendations in the report. We wanted to seek independent evaluations of the FCC radiation guidelines, work with federal legislators to revisit wireless regulations, take action to alert the public about the dangers of cell phone radiation. We thought about having public service announcements, social media, websites. We want to work with schools to minimize students' exposures, to encourage the migration to wired networking where possible. And one of our recommendations was to establish a 500-meter setback for all cell phone towers. Again, like I said, we're not trying to, you can go back, forward, that's okay. We're not trying to get rid of technology, but if you use fiber optics, you hardwire, you minimize your wireless radiation, not only will it be healthier, but it's also safer from a privacy and hacking standpoint. So how low-level wireless radiation affects health, humans, wildlife, and plant life. The primary mechanism is shown to be oxidative stress. As you all know, oxidative stress creates free radicals. The free radicals are the atoms or molecules with an odd unpaired number of electrons. They can be formed when oxygen interacts with certain molecules. An excess of free radicals leads to chronic inflammation, which can lead to a host of adverse outcomes. These effects, including cancer, lower fertility, lowered immune system, diabetes, all of this is, including premature aging, is coming from all of this abundance of free radicals. And we know we can try to do things with supplements and eating correctly, but it's just not enough if we're constantly bombarded. Okay. We can go to the next, please. So this is just a little something I wanted to share. What happens when people are exposed to strong wireless radiation, but way below the FCC threshold. So the FCC threshold is just not accurate, and people are being harmed. So what ended up happening is they thought it would be a good idea to put these cell phone towers right on top of the fire station. It made sense at the time. So before it got turned on, everything was fine. As soon as it got turned on, they noticed that all of the fire people were having the same symptoms. They were having headaches, nausea, insomnia, heart arrhythmia, depression. So they decided to mimic this in laboratory from what you would get from your iPhones in the towers. And they were able to show that it is absolutely 100% true. Less than 5% of the FCC limits is what is shown. Representative Woods, if you want to add anything, you were right by my side while we did all of this. Feel free. We can go to the next slide. That's really basically what I got a little ahead of myself, but that's what happened when the cell phone towers got turned on. And I'll ask you to reference Physicians for Safe Technology, and that will help you to know a little bit more about this. We can move on. So meta study of 38 previous studies showed all the evidence and health risk by RF on humans living around cell phone stations. Motor phone base is the same terminology for the cell phone towers, from radio frequency sickness to cancer. So 73.6% of the studies showed effects of radio frequency sickness, and 76.9% showed an increase in cancer rates. 75% of the studies showed changes in biochemical parameters, and studies also showed negative impacts on animals and trees. So we can move on. So the mortality by cancer and cellular telephone base stations in the this Belo municipality, they explored the relationship between cancer rates and the distance of people who lived closer or further away from the cell phone towers. What I found was interesting is that the study investigated a large number of cancer deaths, 7,191, and a large number of towers, 856. So this was performed during a time when fewer people really had their personal devices. Not everybody was using cell phone towers cell phones like we do now. So the results of the study revealed the effects of living near a cell phone tower. And we can go to the next slide. So the takeaway from this study is that the blue line is the death rate for the population in general, And the red line is the stage of living 1 kilometer away. And as you get far enough away from the tower, the two lines intersect. So the death rates from the cancer becomes the same as the death rate for the population in general. It's a monotonic decline. Also, if you feel the need at some point, more qualified experts that can speak to this, like Dr. Kent Chamberlain, who's at UNH. We have lots of people that would be very willing to come and speak to you at any point. On the next slide, there are different results that compare to other countries. The health outcomes are as chronic disease illnesses, and it means more people are getting radiated at a greater degree. So it's our threshold for radiation is very different. It's very high compared to the rest of the country. So that really is very bad. I mean, our standards are terrible in comparison, and we are seeing the outcome of radiation due to it. And then we can go to the next slide. Thank you. So examples that can happen, as you can click on all of these links at your leisure, but usually right away when you live that close, you will have those sleep disturbances, headaches, insomnia, depression, fatigue, tiredness, trouble concentrating, memory changes, dizziness, irritability. We also have many people in New Hampshire that we met on our commission that have electromagnetic sensitivity, and it's very bad. I mean, many of them, they cannot leave their home, or they get very, very sick. I kind of look at it as air pollution. The more air pollution, the worse things get, the worse it becomes. Well, the same is going to happen with more increase with devices, people in their homes. You know, we have our routers, we have smart TVs, the Internet of Things, the phones. I always like to make a suggestion. I've heard many people say it helps. That's to do an experiment. If you find you have any of these symptoms, turn your router off at night for a couple of months and put your phone in airplane mode and see if you don't notice a difference in how you feel and how you sleep. Okay. The next slide, please. So some show harm while others do not, with all of the studies that have been published with cell phone radiation. So in 2010, that study of 326 peer-reviewed publications was found that 28% of the industry-funded studies showed a biological effect from cell phone radiation. So I still find that high, and that's from the industry. I still think 28% is high. 66% of non-industry funded studies showed a biological effect. So in a 2020, a review of around 1,000 studies showed, as time moved on 10 years later, a decade later, 65% of all studies showed genetic effects from wireless radiation. 73% showed neurological effects, and 91% showed free radical oxidative damage effects. I think that's very, very, very high. I mean, I think it's very telling. And the next slide. So I wanted you to see examples of medical and scientific organizations that are acknowledging the harmful effects of wireless radiation. And they are listed there: Physicians for Safe Technology, the American Academy of Pediatrics, the EMF Scientist Appeal to the United Nations, Environmental Working Group, the Natural Resource Defense Council, Environmental Health Trust, which I believe Representative Salloway had done some work, Dr. Davis there, the consensus statement of the UK and international medical and scientific experts. Again, you can follow up by clicking on the links. And then we've talked about these symptoms, so I won't repeat it to you again, but the mechanisms are known. There were studies done in the Stein and Udasian in 2020, and they wrote a clear summary of electrosensitivity mechanisms, noting the similarities. There's multiple chemical sensitivities, and the mechanism is related to oxidative stress and alterations of calcium channeling signaling. It's not uncommon, and I won't read all this through because you can see it, but it's just confirming that there are a large number of people affected by electromagnetic sensitivity, and it's going to increase over time, and that the number of reported cases has been steadily increasing since it was first documented in 1991. And I will add that when I was doing all this research years ago, I was using the computer, working hard online, and I actually found a stamped government document from 1995, and it was from the EPA to the FCC, and it was telling them that you cannot keep going forward with all of this till we do more studies because of thermal and not non-thermal heating of tissues. And the stamp document responding from the FCC was that they are not to release these studies, and that they were taking it away from a health organization, and the FCC was taking over, and they are not a health organization. And it was then that they decided to put the Telecommunications Act of 1996 in play. And I feel that this has got to be reversed because it's so outdated and so old. The next slide, please. So our conclusions are that many independent scientists conclude long-term exposure to low-level wireless radiation is very harmful and can cause a wide range of adverse health effects. Those effects are found in human studies. They have been replicated in the laboratory. And although some studies reported in the peer-reviewed literature do not show an effect from wireless radiation, the vast majority do. And a number of governmental agencies, particularly those headed by political appointees, claim that there is no harm from wireless radiation. But there is conclusive proof that shows differently. Unfortunately, the profit is greater for wireless than fiber, but moving to fiber would be a much better decision for everyone. So I do thank you for the time to add this to our working group. And again, if Representative Salloway didn't suggest it, I probably wouldn't have put this in with this group, but I think it all goes together. So thank you.
Thank you, Senator. That was a good presentation. Any questions from the commission? I had a question actually for Representative Woods or perhaps Senator Riccardi. It was my understanding, so those cell tower studies were done before 5G was even implemented. Is my understanding that 5G has more attenuation than the earlier cell, the 3G or 4G towers did. Is that something you guys talked about, or is that true or not true?
Do you want to answer?
Yeah.
Gary?
Sure. No, attenuation is very clear. That's why the towers have to be so close. And that's why the issue is raised that because of that attenuation, two things have to occur. You have to have proximity to the destination, i.e. your home computer, and also the fact that it can be focused. So that leads to intensity. There are many other factors that come into play, and these were brought out during the commission from a basic science perspective. It's not just the radiation itself, it's the on and off, because there is a spike in the intensity once it goes on and when it goes off. And that intensity greatly exceeds some of the measurement parameters that they like to quote in the FCC work that was done so far. Also, you may have picked up the comment in one of the slides that and this has been parroted throughout the presentations that in fact, the only damage that can be done is if it's heated, like a microwave. You put your soup in the microwave and you turn it on and it gets heated. And just recently, there was a subcommittee to look at the legislation. And again, a quotes scientist said there is absolutely no harm done other than heating. Myself and Dr. Chamberlain and another individual countermanded that. Again, although I retired as an orthopedic hand surgeon, my original role was a physicist. It's interesting to think back that in 1964, as a senior at Berkeley in physics, I was looking at the quantum mechanics of interaction in molecules, which is directly applicable to this process. And in fact, I gave a couple of examples of where the mechanism of radiation at the molecular level requires almost infinitely less energy to create damage. That is, create a genetic defect or some other mechanism that would create an ionized process that's far below the thermal level. So when you hear that, that's one of the key factors that we have to understand, that it is not just thermal, that at the quantum mechanical level, our molecules are active at that level. And the example I give is, how do you see? And I often ask, where's the nearest quantum particle detector? It's your eye. Because every photon that enters triggers a cis-trans isomerization in a molecule. It makes the molecule switch. That's a teeny tiny amount of energy. That stimulates that rod to stimulate an optic nerve. And it's that collection of all of those little individual photons, that's how you see. So we know that our body is sensitive to these. If it's sensitive in a positive way, like our eyes, we also know, and we see it on a regular basis, that it can be sensitive to abnormal types of radiation, i.e. the 5G. So we have to get away from this industry business about it's just the thermal aspect, because it's not. And I keep harping on that, and I just want to take a moment to emphasize that. But it's a significantly an uphill battle, but the commission, I think, did a really very good job. It was put together well, and it's been received well throughout our country, but also it's now been circulated in Europe as an example.
Excellent. Any other questions or comments from anyone? Thank you, Dr. Woods. Okay. Thanks for that presentation, Senator. Just moving on. So Representative Muse is here. He's just getting started with the subcommittee and don't think he really has anything prepared to speak to us about, but I do think the subcommittee will be an important function because that commission has ended and there is still a big need to have some sort of oversight of that issue, more so now than maybe before even. So I'm happy that Representative Muse has agreed to take that on. If anyone here wants to be part of that, I certainly will be. Please just let Representative Muse know that you'd like to participate in that. As we talked at the beginning with Dr. Bove, that cancer cluster in the Seacoast area and the other issues around peas still persist and are still problematic in our community. So we need to really address the causes, potential causes of those cancer cases in our children. So thank you for doing that. Anything you want to say at this point?
No, I've been associated with this issue for probably 4 or 5 years now. Both Pease and Coakley. In Portsmouth, we have the unusual, I don't want to call it an honor, but we're in the unusual position of being a responsible party when it comes to Coakley and a victim when it comes to Pease. So I think one of the things that we have is an obligation to do as much as we can to help get to the bottom of this, to continue to investigate and really try to get to a point where we can get to some conclusions about what's going on, so we can actually get the kind of help that we need. It's very, very difficult. One of the things that I learned on the Seacoast Cancer Cluster Commission is how hard and how frustrating it is for legislative committees who have to deal with a very narrow time frame to come up with conclusions and recommendations to deal with an issue where the science can sometimes take decades to evolve. So the fact that we're able to pick up some of the work that we were not able to complete in the Seacoast Cancer Cluster Commission, and perhaps transfer it over here and continue some of that work and continue to have some sort of legislative oversight over what's going on in this area, I think is really important. And so I'm glad that I was asked to do this, and I need all the help I can get. So.
We all do for all these things, but. All right, moving on. So just wanted to inform the commission that lead bill was signed into law by the governor, which is amazing. That will bring about $36 million, I believe, or $38 million into the state to address lead service lines and lead issues in our schools, which is extremely important. And it will cover testing and remediation for those schools. There are very high ranges, anything from non-detect lead to as high as 8 or 10,000 parts per billion of lead in some of our school drinking water systems. So super important. We talked about things like autism here with Dr. Bove. That will go a long way to addressing some of these issues that we're seeing in our schools and in our towns. So really happy to report that. That's amazing. As I said in the beginning, I think we'll have to track this MOU issue here between DHHS and DES and possible need for more legislation in the fall. And that's all I have for now. I know that, there are some who are incumbents, some who are leaving, some who are coming in, hopefully. But maybe between now and our next meeting, we can all possibly, suggest any possible legislative proposals to via email before the next meeting, which is going to be around this time in September again, to us. And if you have ideas for needed legislation, maybe the commission can propose them to some of our legislative colleagues and support those measures. Any of the work that has come out of this commission, I think there's a lot to be done. I feel like my head's exploding all the time with all this stuff, but a little chipping away at the lead issue, is a good example. We've been involved with that lead issue here for many of us 5-6 years, and we've gotten some really good stuff in place, but there's other stuff to be done. So if you want to send me an email, if you have any ideas, and between now and our next meeting, mid-September. I also saw that Peg will be interested to hear this. There's some grant money coming into somewhere to inform physicians, and maybe Dr. Cazal can be involved in this a little bit too, on the environmental health impacts in our community. So informing physicians, letting them know about some of the stuff. Peg did a great job with Nancy and some other people in, we talked in previous meetings, Dr. Cazal, about the nurse practitioners event. Maybe Peg, you can just give him a quick rundown so he's aware of what happened. But this is the idea that we had that really should be broadened to physicians and people across the state of New Hampshire.
Okay.
Yeah, sure. Dr. Cazal, so I represent the New Hampshire Nurse Practitioner Association on this commission. And so as part of that role, I helped organize with HHS and DES a session presentation at the New England Nurse Practitioner Association meeting and last April. And we will be doing that again next April. And it was a wonderful opportunity for us to start the education process for a very large group of clinicians. So I hope that the model can be duplicated for the physician community as well.
Yeah, great feedback from that event that we've heard.
Yeah.
All right, any other new business from anyone that would like to bring up to the commission? Okay, seeing none, I guess that's it for today. I will get this room reserved again probably for next month, and we'll see you in a month. Good luck in elections if we don't see some of you who are running again. Thank you so much, you guys.
Okay.
And
Bye-bye.
thank you for everything
Thanks.
you do
This
and
was
sharing.
terrific.
Thank you.
Thank you, Mindy. Thanks to presenters. Bye.